2 thoughts for the day. Ready? First one. Why did the hamster cross the road? It was the chicken's day off, of course. Alright, think about the authors, right? I don't know what the age range on that author, but I'm guessing it's a little on the lower side. I know which one this one is. This one's the face. What type of dinosaur does things really quickly? A Brontosaurus. Okay. If you take a look at the syllabus and where we're at, we're actually right on track. We're in our last unit. So today we're going to be covering renal and liver. We're going to kind of do 2 topics in one lecture. Do the first one, take a break, and do the second one. And we're on the home stretch. You guys happy about that? Home stretch. So hopefully at this point in the semester, you're pretty familiar with the pace, you're pretty familiar with the schedule, and there shouldn't be a whole lot of surprises. We should be pretty dialed in now. When we look at the topics today, we're going to cover renal and then liver. There are some similarities between these 2 systems, and that's why I've kind of lumped them together. The similarities are more from the pathology side of things. You know, both of these organs are filtering organs. So they're going to take blood and they're going to filter blood. They're going to, in some cases, add certain things to the blood. In other cases, they're going to take quite a bit out. So we're going to look at them collectively together, but we're going to do them sequentially. Awful lot of review that can take place with both of these organs. Okay, so I'm going to encourage you, outside of the lecture time, to make sure that you're comfortable or refamiliarize yourself with the background on renal physiology. So let's test it, your knowledge. So the area of the kidneys which contain the glomerular are known as what? No idea? Even though there's a big red green arrow on your slide. Okay, it's the cortex. All right. If we look at the architecture, this slide should be somewhat familiar to you. We're going to look at some different categories of diseases. And of course, those diseases are going to be based upon really the location that they take place in. So we'll look at some glomerular disorders, which obviously is at the level of the glomerulus. We'll look at renal failure, which involves the entire kidney. And we'll look at various infections that can take place. And those infections can happen anywhere throughout the urinary system. So these include urinary tract infections, known as UTIs, bladder infections. It could also include a kidney infection. And the level of severity is sort of in that order. UTI being lowest severity and kidney being the most severe. A kidney infection, if it goes untreated or is chronic in nature, actually could destroy the kidney altogether. The architecture of the kidney is shown here. You can see on the outer side is this capsule, and we have underneath the capsule, just deep to the capsule, is this renal cortex. And then deep inside, organized in these triangular pyramid-like structures, are what we call the renal medulla. And so the architecture of the kidney is very specific. We'll look at histology, it'll be pretty clear. It should conjure up, some memories of 202 when you were looking at some of the architecture of the kidney. Okay, so we're going to kind of keep this architecture in mind as we look at the different types of diseases throughout today. Now, the nephron is the basic structural and functional unit of the kidney. The entire nephron. Now, the glomerulus, what was the glomerulus? Do you remember what the glomerulus was? It's where filtration occurs. Okay, so how would you filter then? what kind of two things do you need in order to filter? What are you filtering? Let's start there. Blood. Okay, so you probably need blood, right? And what gets the blood there? Okay, thank you. Vasculature. So you have blood vessels bringing blood to the kidney down into a capillary architecture, and then it forms sort of a tuft. And the endothelium there is very leaky. And then you have a space that you surround that tuft of capillaries with a capsule, Bowman's capsule. Right? So when you filter the blood, it doesn't just go into your peritoneum. It actually is captured within a structure, and then you do something with that filtrate. Okay, filtrate is actually the beginning phases of urine. Right? We can measure that filtration rate. We call that what? Glomerular filtration rate, interestingly enough, because we're at the level of the glomerulus. Is this all bringing up some old memories? Okay, so if that's a little foreign, maybe take a peek at just the architecture. Go to your A&P text, right? Get into the urinaries where you see these big loops. Remember those? Proximal convoluted tubule, the distal convoluted tubule, the collecting duct. Well, the glomerulus is before all that. Okay, so you'll see this. It'll be like a full page, most likely, or 3/4 of a page. And there's going to be these different zones. You'll see some numbers. Remember the numbers and how we concentrate urine. Okay, so that's the function of the kidney. The nephron itself is the whole architecture, right? The nephron involves all of that tubular network as well as the glomerulus. Okay, so if we look back at a slightly different picture, the glomerulus now, we call that the basic filtration unit of the kidney. So the nephron is the structural and functional unit, and the filtration unit is the glomerulus. And where are we? Well, if you, this is on the right side of the body, obviously. So here is our renal artery and vein. Renal artery brings in blood flow into the kidney from the aorta. And as it enters into the kidney, it gets into smaller and smaller architecture. And here at the level of this renal pyramid is where you start seeing the architecture of the nephron. Okay, and as you work your way from the superficial most portion to the deepest portion, right, you're filtering blood here, and you're creating and collecting urine down here in the deepest part. And eventually all of this empties into what structure? What structure is that? What structure is it? The ureter. Okay? So this one's labeled. And you can see the drawing here showing these major calyces that collect it into the ureter. And the ureter goes where? To the bladder. The bladder stores the urine to a certain level or stretch, and then it decides to stimulate what's known as the mituration reflex. Remember that? That's that urge to pee, and then it leaves the body through what? The urethra. Okay? Remember, men and women both have urethras. Okay? Obviously, the men is longer than the woman's. Okay? But UTIs can happen anywhere along, or infections can happen anywhere along that system that I just described. Anywhere along that pathway, you can get an infection. If it's called a urinary tract infection, it's usually in the urethra. And then obviously, if it makes it back into the bladder, it would be a bladder infection. If it makes it upwards into the ureters, now your kidney itself is at risk. Okay, and the problem when it gets up in here is we don't have a lot of nociception in that tissue. So the patient will say that a UTI hurts worse than like a kidney infection. Kind of weird, but it's the body's potential early way of detecting or telling you there's something wrong. Okay, if it's retrograde. We can also get infections that come anterograde, and we'll talk about those. Retrograde is something from the outside of the body coming up the urethra. Okay, so this is all review, right? Now we've got some terms, and some of these terms may be a little bit new. So let's talk about it. Urea should be new, but what is urea? Well, this is a catabolism or the breakdown of amino acids. Okay? Azotemia, this is an elevation of Bun levels. Bun levels are blood, urea, nitrogen. So this happens when you have protein metabolism taking place, and you're going to get a lot of breakdown products of protein metabolism. And when we see high levels of protein metabolism happening, we see what we call azotemia, meaning you have high blood, urea, and nitrogen levels within the urine. How about uremia? This is a term that generally or loosely describes a illness or a problem associated with kidney failure. Uremia. It's a disease stage. Proteinuria. Any guesses as to what that is?
Protein in the urine.
Protein in the urine. Usually we shouldn't have lots of protein in the urine. So remember that filtration unit, the glomerulus? Right? It has a leaky vasculature. It's like a sieve, right? It's like a colander. In fact, if you under microscopy look at the endothelium at the level of the kidney, it looks like a colander that, you make noodles and you pour it in a colander and you strain the water. If you hold it up, you can see these holes through it. That's kind of what that epithelium or endothelium looks like. But the holes are small enough that protein, which are large molecules, can't fit through. So if you have proteinuria, that usually tells you something's not right. Okay, how about glycosuria? That's not even on here. Glycosuria. Glycosuria. Sugar in the urine, or glucose in the urine. Hematuria. That one's on here. What's that? Blood in the urine, specifically what elements of blood? The red blood cells, okay? Erythrocytes. You'll be hearing about those on that talk on Friday that I was talking about. Pyuria, white blood cells in the urine. And then oliguria. Oliguria. What is that? Decreased urine production. Low urine production. Not a good sign, actually. Low urine production usually means something's not right with the kidney. It's not filtering the way it's supposed to be filtering. Yeah, you should have a very regular filtration rate. You should be making urine pretty consistently throughout your day. Okay? All right. So these are a lot of clinical terms. Most of them should be relatively review, but I'd like to go through them just in case maybe you took 202 at a different institution, or maybe it wasn't a focus in your particular section. All right, so that sets up the background, like we kind of always do. We talk about really, the physiology and the anatomy first, and now we're going to talk about some of the diseases. Okay, so first up, let's look at glomerular diseases. We're going to look at glomerular diseases first. Okay, and then we'll look at diseases of the tubular network, of the nephron. So a glomerular disease is a disorder that impacts the functionality of the glomerulus, otherwise known as glomerular function. So that's going to change or alter or influence filtration rate at the glomerulus, or glomerular filtration rate. That GFR is directly proportional to urine production. So if GFR goes up, urine production is higher. If GFR goes down, urine production goes down. Okay? So if you're measuring in a patient urine production over time, you're getting a it's an indirect, but it's very, very near direct indicator of GFR. Make sense? So when you give a urine sample for a healthy visit or a wellness visit, or if you're not feeling well, they're not just looking for stuff in there. They're also going to look at the amount of urine that's produced. Okay? All right. Many of these diseases are immunological in nature. Hence why we cover the immune system. We don't go into a full workup on immunology in this course. In fact, we have a great course in immunology here at our institution. You guys, if you're interested in a lot of these immune questions, the immunology section or course, the full semester on immunology, would be fantastic for you to look into. But we at least have to cover it in a cursory view so we can set up a lot of these disease states, like what we're going to talk about here. Some of the examples that we're going to look at: glomerular nephritis, diabetic nephropathy, and nephrosclerosis. So glomerular nephritis is basically an inflammatory disease that really starts at the level of the glomerulus. Diabetic nephropathy, this is where you get a buildup or accumulation of matrix proteins, extracellular matrix proteins, ECM. And that buildup occurs at the level of the basement membrane of the glomerulus, so the glomerular basement membrane. So it says here you have an accumulation of ECM in the GBM, right? Extracellular matrix builds up in the basement membrane of the glomerulus. And then lastly, what we're going to look at is kind of an outline. We're going to look at nephrosclerosis. This is a disorder that targets the arterioles of the kidney. And they become damaged, and they become scarred. And as they scar and become damaged, you restrict blood flow, and you actually prevent filtration, right? Because if the walls of the blood vessel are scarred, is it going to allow for that colander filtration activity to happen better, or is it going to compromise it? It's going to compromise it. Okay? So this is what we're going to talk about in today's lecture. So let's look first at glomerular nephritis. Well, we said it was inflammation of the glomerulus. We know all about that in this class. We know about inflammation. Bless you. The pathogenesis. Well, the pathogenesis is immunological in nature. It involves antibodies. And the antibodies can either be in two different formats that should conjure up some old memories when we talked about type 3 hypersensitivity and type 2 hypersensitivity. Okay, so these antibodies, the first type we call is circulating. So in the circulating situation, which is the picture that's on the left, the lower left, you've got an antibody-antigen complex that forms in the bloodstream. Right? So the antibody-antigen complex forms in the bloodstream. Remember type 3? And then it circulates throughout the body, and it gets lodged or it gets stuck in certain types of tissues. If you look back at your notes, one of the tissues we brought up was the kidney. When we talked about glomerular nephritis, there was a slide that showed that name. So that name you've actually already heard. Well, that's this right here. So we're at the level of the kidney, and this is our circulating antibody that's in the blood vessel. This is the cross-section through a blood vessel. This structure right here, this sort of S structure, is the basement membrane. You can see it's labeled right here on the left. And this complex, because it looks like, a Y with the antigen stuck to it, these complexes circulate and they get stuck as they filter, because they don't go through those holes, those columnar holes. And this causes an inflammatory reaction because you have this antibody complex that recruits inflammatory mediators to the location. Right? You're going to get the recruitment of neutrophils, you're going to get the recruitment of macrophages, and you're going to get swelling and all the things that we covered earlier in the semester with respect to inflammation. Okay, so that's the first type, type 3 hypersensitivity. So what would that antibody be? Well, it would be an antibody to some antigen that could be found really anywhere floating in the vasculature. Okay, it could be to some element of the blood vessel wall, but it doesn't stick to the blood vessel wall. It actually kind of comes loose and floats around. Okay, then the next type is called in situ, in situ. That's a word that means in location. And this is more of a type 2 hypersensitivity strategy. Remember type 2? Type 2 is where the antibody has a reaction towards the antigen, and the antigen is found on a piece of tissue. Not something that's circulating around, it's something that's there. So the tissue that is reactive could be one of 2 types of tissues in the glomerulus. The middle picture is showing it's actually towards the basement membrane. And so you can see in the blood vessel, instead of over here where it actually has an antigen attached to it, it's just the dimer, it's just the Y, remember that? And that little Y guy is floating around because it's reacting towards an antigen that makes up the basement membrane. The second subtype of in situ is it's some glomerular antigen that isn't reactive to the basement membrane. It's some other feature of the glomerulus. And you can see that the reaction is happening sort of deep to the basement membrane, and it's kind of on this other side of the basement membrane. You can kind of see, if you look closely at your slides, you can kind of see 3 distinct patterns of antibody reactivity. So this is glomerulonephritis. Glomerulonephritis, inflammation at the level of the glomerulus. So these antibody-antigen complexes form, whether it's circulating or in situ. You trigger and activate complement, because complement is found in the bloodstream. Remember that? You recruit your inflammatory mediators, neutrophils, macrophages, etc. You degranulate those things. You send out their enzymes, their reactive oxygen species, their cytokines. And then what you do is you start eventually laying down scar or fibrin. Remember, scarring or fibrin deposition is sort of the end phase of inflammation. You guys remember that? Just a normal wound healing process is being used, but it's a pathological use of normal wound healing. Okay, so now you've got this scarring that's taking place at the level of the glomerulus. Okay, so if I'm going to dim the light so you can see this a little bit better. If we take a look at what this looks like using immunohistochemistry, we're going to see 2 distinct patterns. Okay, we've got, the way this immunohistochemistry works is, how many of you are familiar with immunohistochemistry? Like 2, 3. Okay. So what we can do is we've become very clever in the field. We can develop an antibody that recognizes an antigen that we want to look at. Okay? So we build that antibody. Usually you'll grow it up in a different mammalian system. Like you grow it up in a mouse or you grow up in a rabbit. And it has an affinity, usually as a mammal if you're going to try to look at human tissue. It has affinity for human tissue as well. Then what you do is you have to either label it or tag it with a fluorochrome. And when you hit it with a certain wavelength of light, it actually fluoresces and it gives off light. So you activate it with one energy form and it raises it to another energy form, and as it loses energy, it gives off this light. And that's what you're seeing. Okay? So on the left side, you hit it with a light, and as it gives off light, it gives off light at the green wavelength. In this one, it's more of a yellow wavelength that it's actually fluorescing now. Okay, so that's the principle behind it. Beyond that, what I really want you to understand is, do you see how this staining pattern, if you look over on the edges, the far left of the left image, you can kind of see how it's punctate and stained. If you look in contrast at the right image, anywhere along the right image, it looks like a very thick Sharpie marker. It's continuous. Does that make you with me? So here you can see lots of evidence of dots or kind of distinct punctate staining. And over here it's more linear in nature. So given that descriptor, which one of you, or which one of these do you think would be a circulating type? Circulating type. So let me back up. Circulating type is this far left. Remember that? And in situ are these two pictures. They're nicely spread out, more linear and uniform. And here is like there's a cluster, there's a cluster, there's a cluster. Oh, Feller, you just gave it away. I'm trying to make it pretty darn obvious. So which one of these would you argue would be circular pattern of staining? Circulating, excuse me. A, why? Because it's got the dots, right? It's got the clusters of where they get lodged or stuck. That's exactly right. Over here, this is in situ characteristic. Over here, this is circulating. Okay? So we would call this more granular in appearance, and we call this more linear in characteristic. Clear? All right, so let's look at a couple of different subtypes of glomerulonephritis. If we look at glomerulonephritis, we're going to see three main subtypes. We're going to look at rapidly progressing, we're going to look at acute diffuse, and then we're going to look at chronic. So rapidly progressing, acute, and chronic. Three of them, three types of glomerulonephritis. Rapidly progressing is shown here. You can see a normal glomerulus on the left. So let's just look at the histology to orient ourselves. Okay, so you can see this is the cluster of blood vessels right here, right? And this is Bowman's capsule, this outer covering, and you can see the space, the white space that surrounds it, right? That's where the filtrate shows up. Pretty clear, right? Over here, look at what's happening here. Here's a glomerulus. Here's another glomerulus. Okay? They definitely don't look the same. Okay? And they look unhealthy. Why? Well, the number one thing that you're going to look at, all right, light show, is you see these sort of crescent shapes right here? These crescent shapes are scarring at the level of the glomerulus. So this sort of crescent-like appearance is what you've been looking at. You don't see that here. You don't see any thickening or any areas of scarring that takes place. You can see that happening here. Also, you're actually able to appreciate in what would be Bowman's space. You see this, where it should be nice and devoid. It should be devoid of cells. It actually is filled with cells. You see all the purple dots? You can even see it in this one. What are those cells? What do you think those cells are? What's that? They're inflammatory mediators, inflammatory cells. Okay, white blood cells that have extravasated out. Okay, monocytes. They're now becoming macrophages. So with rapidly progressing, the causes are usually something that's post-infection. Okay, or it's commonly associated with systemic lupus. A lot of these patients will have rapidly progressing glomerulonephritis. What ends up happening is you get a rapid loss of function. GFR rate goes down. You get tremendous leakage of protein. So proteinuria goes up because you have this major scarring that takes place, and this inflammation causes sort of these large holes in the endothelium. And that allows for proteins to kind of leak out. Okay? All right, now if we look at the next subtype, this is acute diffuse. The most common way that acute diffuse shows up is usually a post-strep infection. There's a common patient age, usually it's younger patients, 6 to 10 years of age, although it can happen in any age group. But 6 to 10 years of age is kind of like the sweet spot for strep infections. Okay? You can use that terminology together, right? It's kind of messed up. Sweet spot for infections, right? The onset's usually 1 to 4 weeks, so 7 to 28 days after infection. It doesn't always have to be strep. It could be a staph infection, a pneumococcal infection. There are some viral stimulants or causes as well. Strep is probably the number one. And the infectious agent, the antigen, gets trapped in the basement membrane. And then the antibodies that are circulating around go and attack that particular antigen. And if it's lodged in the basement membrane, it looks like an attack against the basement membrane. So it's very linear in staining pattern, right? It looks in situ. So the this antigen gets stuck because that infection is in the blood. And it's circulating around, it gets lodged in the basement membrane. Your antibody actually binds to it and causes a reaction. So you can see this architecture here. You don't see this crescent moon shape, right? You don't see a lot of scarring with acute diffuse, but you see a lot of inflammatory cells within Bowman's space. So if I back up again, it would be the same control picture here. Is the Bowman's space should actually be completely devoid of cells. Here you can see that there are inflammatory cells sitting within Bowman's space. Okay, the third category is chronic. Now, both rapidly progressing and acute are treatable. But we have to get to the root cause. And the problem is, if you have an infection happening at the level of the kidney, a lot of times there's not a tremendous amount of pain associated with it. Not like a urinary tract infection. Has anybody seen the Green Mile, the movie? Yes, it's with Tom Hanks. It's kind of an older movie. It's about prisoners on death row, capital punishment. Okay. Tom Hanks is just a great actor. So, I mean, if you haven't seen the movie, it's actually a good movie. It has nothing to do with this. However, it does in this arena, is he had a really bad urinary tract infection. Okay? And so they show pictures of him like going to the bathroom. This is kind of weird, but pretend I'm going to the bathroom. And he's like, oh! I mean, it is like so painful. But a glomerulonephritis, an attack of the kidney, would not have that level of pain just because you don't have the same nociception. Okay? So these are treatable. This is one that is past the point of treatment. This is chronic glomerulonephritis. So a lot of times the other two stages will move on. If they don't get treated, acute glomerulonephritis doesn't get treated, that strep infection of that patient ends up being caught by the kidney. And now you get an infection there that's more long-term. Now you have what we call chronic glomerulonephritis. This is a frequent cause of renal failure. And you get a tremendous amount of scarring. And you get loss of the nephron, complete loss of the nephron. So this is a histology on the left. And this is what we call a Mason's trichrome. And I know there's one student here that knows this slide pretty well, what it stands for, but I want them to remain quiet so the rest of you can try to answer the question. What is the blue in a Mason's trichrome highlight? What type of connective tissue specifically? What protein? Collagen. So the blue likes to highlight collagen. So do you see this right here, this structure? This is kind of a funky looking glomerulus because look at how thick the capsule is, or how wide it is. Well, this is probably still working. This one here. This is an old glomerulus that no longer is there. What has replaced it? Scar tissue. Collagen. It's just like having, a scar on your arm. But this is within the kidney itself. How about this one right here? Same thing, right? So you've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I count 11. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10. That's a nice number. Let's call it 10. So you have 10 glomeruli on this slide. You've got 1, 2, 3, 4, 5, 6. They're gone. So if you did that, and you looked at the entire, and you said that that was representative of the entire kidney, you would say that you probably are down to 40% functionality of that particular kidney. Now, who knows what's happening on the other side, right? Because you have two. But, I mean, that would be a very quick overview of how you would determine histologically what's going on. You'd see if their GFR rate was actually compromised by 60%. Probably was pretty close to that. Okay? Is this reversible based upon what you know about healing from this semester? Why? Why is it not reversible? You're the physician. I just got my past report back and you're consulting me. You're saying, I said, well, can you fix me? Why not? You're the doctor. What's wrong with you? I thought you went to medical school. Why can't you fix me? What's that? You've lost function. The body is already healed. It healed it, though, with a scar instead of returning functionality to the tissue. So it's like when you fell off your skateboard, you know, when you were a kid, you had that giant scar across your arm. That's the body's way of trying to heal it, but not returning function back to the tissue. That's why you got a big giant scar on your arm. Well, that's happened to your kidney, unfortunately. So now you kind of have the tools to explain the difference between why this is not reversible. Okay. Now this is at explant, so this is a post-mortem view of the kidney, and it's kind of hard to appreciate, so I just have to describe it. But if you look at this, it has sort of this bumpy appearance to it. So if you ran your hands over across of this, it would actually have like a cobblestone bump to it. And this is a pretty aggressive, scarred kidney where you're feeling these scars at the level of the surface as little bump rises as you put your hand over top of them. Okay, you gotta put your sandwich down before you like rub your hand across. Otherwise you can't really appreciate how it feels. Chronic glomerulonephritis. Okay. So I want you to answer this question with your neighbor. What would you expect would result in a patient that had chronic glomerulonephritis? Make a list. There's lots of space here. Some of the symptoms, clinical symptoms that follow. Here's some ideas. Pretend your patient's kidney looks like that, but you don't know that yet. You haven't done a biopsy. What are some things that you're going to see that's going to lead you to believe that maybe you should get a biopsy? Decreased GFR, I would agree. We would also refer to that using one of those earlier terms, what?
Oliguria.
Oliguria. Okay? Low urine production, decreased GFR. Scientific community would say decreased GFR, right? The clinical community would say low urine production. You're kind of saying the same thing, right? But you're just speaking slightly two different languages. What else?
Proteinuria.
Proteinuria, yep. You would see protein in the urine. You're going to probably see what else in the urine too?
White blood cells.
That you should white blood cells and or red blood cells. Okay, I mean if there looks visibly to be red blood in the urine, most patients are like, oh dear, I should probably go see somebody. Okay? But it may be small enough in number that you can't visibly tell the difference, okay, with your eye. But upon an analysis, you would see erythrocytes. Erythrocytes are about 7 to 10 microns in diameter, so to see visible blood means that something's really bad. But to see red blood cells present that are not visible from the naked eye is very simple to see microscopically. You're looking at, clumping of these red blood cells, and you can see that. Okay, so that's a pretty good list. So you get a urine sample. Patient says, I haven't been feeling so great. Okay, you know what? I've got a lot of swelling in my body, like lots of swelling on the lower legs, a lot of, they wouldn't say this, but a lot of tissue edema, and it's really uncomfortable. By the end of the day, my feet they ache, and my shoes don't fit, and so then you're going to start asking some questions about, okay, so fluid retention. So where else does it feel swollen, right? And when does it feel swollen? So you're going to see a lot of tissue edema because GFR rate is down. Okay, you may or may not see hypertension, depending upon how severe it is. Because if there's not enough fluid leaving, and you're keeping fluid in the system, and that's why the tissues are edemic, that means there's a lot of fluid in the vasculature, so the patient may actually have high blood pressure. That actually might be the first sign. They go to the dentist. Nowadays, how many of you have been to the dentist recently and they take your blood pressure? Okay, that's pretty new. Or actually even to the eye doctor now. Right? This is part of affordable health care, actually. This is one of the things that was actually a very good thing that took place with this new legislation. Right? There are arguments on both sides, but let's not get into that. But this is definitely something that's been helpful. Now you go get your eyes checked, you get your teeth cleaned, and you're going to get some basic, wellness checkups. And that may or may not tell you something's going on, and you should probably go see somebody else. Okay? All right, good. So, yes, question?
So you said there wasn't capacity in acute diffuse GA. Why is there less scarring?
Why is there less scarring in acute diffuse? Why is there less scarring? The process with acute diffuse doesn't scar quite as much because of where the antigen is found. It stimulates a greater inflammatory response, but you don't get a lot of scarring or the capsulish formation. Okay, so with inflammation, as we've talked about, there's kind of two big main pathways that can happen. We talk mostly about fibrosis, right? It comes up and fibrosis is the resolution. Well, if it doesn't ever sort of resolve and have fibrosis, then you're going to get a lot of elevated inflammation. Remember we talked about how foreign body giant cells show up in a chronic inflammatory response, and you get more inflammatory mediators. So you either have kind of a matrix response or a cellular response. A lot of times you don't get both. So with the crescent-shaped acute diffuse, you're getting more of a fibrotic response, and with the acute diffuse, you're getting more of the cellular response on inflammation. Okay. All right, let's look at nephrosclerosis. So nephrosclerosis is scarring in the tubules. Sclerosis is a scar. If we look forward to the last unit, or the last lecture of the semester, we're going to talk about atherosclerosis. Most people have heard that term, atherosclerosis. All right, that's scarring within the vasculature. Nephrosclerosis, same suffix, sclerosis, meaning scarring. So we see this very commonly in diabetics and in patients that are chronically hypertensive. The morphology is a hyaline conversion and an atherosclerotic response of the small blood vessels that are near and around and surrounding the nephron. Okay, so in this picture, what we're seeing is two arterioles with significant hyaline deposition in the wall. Which ones are they? Can you point them out? They should be super obvious. Okay? One sort of in the mid to upper left, and one towards the bottom right. And the thickness of this blood vessel wall should look like this one over here. So here's a normal, quote unquote, normal looking vessel that's halfway on the left edge of this picture. You see it? You see the thickness of that wall? It's about a cell thick. Look at how much thicker these guys are. So this is this sclerotic response. So how does this happen? Well, let's pretend the patient's hypertensive and the vessels are experiencing an increase in load. So the way they're going to respond is by remodeling the architecture to be able to combat that load. And they thicken their wall. So in nephrosclerosis, you get this wall thickening and it compromises filtration. Okay? So what happens clinically? Well, we get protein in the urine. We often see ischemia of the kidneys in very specific areas. If I go back to this histology, you can see these two are affected, but this one right here is not. So you're not going to get global ischemia. You're going to get what we call focal ischemia. You're going to have a decrease in protein that's found in the serum, because if you secrete or excrete lots of protein in the urine, then the levels come down in the blood. All right. Let's take a look at renal failure as sort of our last topic. So we covered glomerulonephritis, right? We talked about the different categories there. We talked about nephrosclerosis. And now I want to talk about renal failure. And this is where we're going to see some a little bit more detail than what we talked about thus far. So if we look at renal failure, we've got acute renal failure that's up first. An acute renal failure is a rapid and a severe decline in the function of the kidney, very, very commonly associated with a decrease in urine production or a decrease in GFR. We have three contributing mechanisms that can cause this reduction in GFR, and they're shown here. Things can happen either before it ends up at the kidney, pre-renal. It can happen at the level of the kidney, which we call parenchymal. Parenchymal, remember, that's a word that means the functional tissue of that organ. And thirdly, we could get renal failure because of something that's happening technically after the kidney, post-renal. And the example that you see here is a urinary tract obstruction. So if you see this picture up here in the right, lower right, you've got these three categories, and they're labeled. Number one is before the blood flow ever gets to the kidney. So the example of number one, or pre-renal, would be shock, right? So the patient actually was in hypovolemic shock. And blood volume or blood flow to the kidney pretty much goes away. If that happens, you're not going to, the kidney's shut down. So in trauma cases, right, one of the second or third things that ends up happening is that the patient stabilizes. If you're a medic, paramedic, or an EMT, and you show up on the scene and it's a major bad case, you stabilize the patient, right? You get vitals, you get them to the emergency department, and they're checking heart and brain, okay? And after they're comfortable with that, then they're looking at renal function. They want to know, especially if there was massive bleeding. You know, let's say it's massive trauma and there's blood that's lost like crazy. Let's say it's a aortic tear, okay? It's just a transection of the aorta, like a motorcycle wreck. If they live, 90% of them die when they transect the aorta, but let's say 10% that live, you would stabilize them, get them to the emergency department, give them fluids, units when they get there or on the way, and then after surgery and they fix the tear and they confirm neurological function, then they're going to be worried about kidney. Okay? Number two, direct damage to the kidney. This could be like inflammation or even toxins. Certain drugs are kidney damaging. This would be in the category of glomerulonephritis, like the ones that we just talked about. Lastly, which we haven't talked about, infections that are urinary tract type infection. So we'll get there, and that's afterwards. And that's, area 3, the ureter, the bladder, or the urethra. Okay, so this is where we're headed. So first up, if we look at the 3 possibilities, we're going to look at infections, and we're going to talk about pyelonephritis, and we'll talk about that in greater detail a little bit later in the lecture. Right now I want to talk about acute tubular necrosis. This is the most common cause of renal failure. And keep in mind that the nephron tubules are the last in line to receive blood flow, so they're the last to get oxygen. So that also means they're the first to be at risk of necrosis if ischemia takes place. So you can have necrosis happening by either an ischemic pathway or a toxin. And you have main activities that take place at the levels of the tubules and blood flow. So let's take a look at this flow chart on the right. If you have an ischemic event, remember that's a decrease in blood flow to the tissue, so oxygen levels go down and tissues become what? Hypoxic. Well, that's going to cause endothelial dysfunction almost immediately because the endothelium are going to be very susceptible to blood flow and oxygenation levels. If the endothelium are damaged, you get vasoconstriction, and this vasoconstriction or narrowing of the vasculature lowers glomerular filtration. So you have vascular responses. Now the blood vessels are going to do some things like you're going to see a decrease in nitric oxide because endothelial cells make nitric oxide. That's the compound that causes vasodilation. Remember, you're also going to see a decrease in prostaglandin. The endothelial cells make that prostaglandin, which also causes vasodilation. So by compromising this, you get this vasoconstriction. You also go over here and you see a whole cascade of events. The bulk of this figure on the right is because of tubular injury. Injury to the nephron tubules, because they're sensitive to oxygenation. Remember, they're the last to get the oxygen, so they're one of the first to become damaged. Well, if you damage the tubule, you can either get a reversible pathway or an irreversible pathway. And basically, the details are not nearly as important as the bottom line. The bottom line is when you restrict blood flow to the tubules, like what you saw on the endothelium, you actually cause damage at the level of the tubules. Some of this could be reversed if it's on this pathway, but if it goes too long, it's irreversible. And if you lower tubular blood flow too much, you're going to compromise glomerular filtration as well. Okay? So if we look at the third category of what can cause acute renal failure, it was the shock one that we were talking about. So shock, this is the situation where you have trauma, show up at the scene, the patient has lost large volumes of blood, and this means that you have an increase in flow to the kidneys. If you decrease in flow. If you decrease flow, you put less in, you get less out, you're going to decrease urine production, and you're going to ultimately compromise the functionality of the kidney. So one question before I answer your question. So shock, what is it? We talked about the categories or the characteristics of it. Reduced ability of the body to return to homeostasis, severe reduced delivery of blood to tissues, getting zapped when you stick your finger in the wall outlet, hyperperfusion of the lungs, or your last grade on the last exam. All right, you should have this answer on your slide. So severe reduction of blood flow to tissues is shock. Question?
So whether the tubular cell injury is reversible or irreversible, it's inevitably going to lead to decreases in GFR.
Yes. Yep. So the question was, if you have reversible or irreversible injury to the tubule, you're going to ultimately have a reduction in GFR. If it's reversible, your reduction in GFR is temporary. It'll come back eventually, but it takes a long time for that to take place. So you still have a decrease in GFR. It's just not a permanent decrease. Does that make sense? The permanent decrease is irreversible. All right. Infections. The last category before we take a break is infections, and it's short. A short little section on infections. So we basically have two main types of infections that can occur. And they're shown on this picture. Most often we think about retrograde, reversed direction. If blood flow comes this way, urine production flows out, then an infection that's retrograde comes up the urethra. Okay? So we think about urinary tract infections, for example. But if you skip to the bottom of the slide, you can see that the causes, the agents that cause these infections, the ascending ones are the ones that come retrograde, like we're kind of used to hearing about. That's sort of our urinary tract infection category. The hematogenous, this is blood-borne, or infections that would come by an infection that's circulating in the bloodstream. So we've talked about that in this lecture already. So this would be like a circulating antibody finds an antigen in the bloodstream and it gets lodged at the level of the glomerulus. That would be a blood-borne infection. Okay? Or a type 2 hypersensitivity, where there is a antigen that's found within the glomerulus or the glomerular-based membrane. You develop an antibody that finds it and causes a reaction in situ, in location, right? That's also a blood-borne or a sort of descending pathway. So if you look at this picture, it kind of characterizes that. So our blood infections, the most common are going to be like E. coli or a staphylococcal infection, and you get a bacteremia in the bloodstream. Okay? It's more common than you think, to be quite blunt. And so you would take a blood sample and you'd see in these patients that there's actually bacteria in their blood. It's not supposed to be there. Okay? What that bacteria does is it gets lodged in the kidney because the kidney is a giant filter. Okay? And your body's probably going to try to attack it. And you're going to have an in situ type of response in the kidney. And if left untreated and if the infection wins, ultimately what's the worst that could happen? You tell me. What's the worst that could happen? What's that? I heard it. Your kidney fails. Remember the chronic glomerulonephritis picture with all of the blue scarring? If that was your entire kidney, you would have no kidney function. Okay? It would fail. You cannot live without both kidneys. You have to have at least one. Okay? So it could be lethal if it's left untreated. Now the other one is an ascending infection, and again, the list of agents, E. coli, Piterius, Enterobacteria, and they come retrograde up the urethra into the bladder. Can actually go from a urinary tract infection to a bladder infection, up the urethra, up the ureter to the kidney itself. Okay, so that process is utilizing what we call a reflux that takes place. We're going to talk about these terminologies here in a second. So if we look at pyelonephritis, pyelonephritis is a bacterial-caused inflammation of different portions of the kidney, the renal pelvis, the parenchymal tissue, or the renal calyces. There are some contributing factors. Females are more sensitive to it than males for a couple of reasons. It's more common in women up to the age of 40. Beyond that, the percentages equal out. Women have shorter urethras, and the prostate and prostatic fluid in males has antibacterial properties that help line the urethra. Okay, so that has a sort of natural protective mechanism in males, but prostatic fluid composition changes as we get older, as men get older. So the amount of antibacterial prostatic fluid content decreases as men get older. So the numbers kind of start equilibrating, if you will. The VUR reflex, this is a reflex that is an abnormal movement, sort of retrograde backflow. Once urine flow stops, there's sort of a slight reflux, pushing the urine slightly backwards. It occurs in all patients at different levels. Some patients, it occurs much more aggressively than in others. Okay? So the analogy is, if you've ever sort of poured fluid out of a tube and then stopped pouring it and you turn off the valve, if you look at the end, you'll see a slight capillary action of the fluid going back to the reservoir. That's sort of that reflux activity that we see even within our piping, if you will. And in some individuals, it's much more aggressive than others. So that retrograde backflow allows for bacteria to come from the outside environment up through the urethra. A urinary tract obstruction. This would decrease urine outflow, so you're not, cleaning out the pipes quite as frequently, so that could cause it. Diabetes is a risk factor. Why is diabetes a risk factor? Because the glucose concentration in diabetic urine, if it's unmanaged, is pretty high. And what do you know about bacteria and sugar water, essentially? Okay, it likes that environment. And so you're kind of creating an environment that has residual glucose in the system. And, if you leave sugar water sitting around, something will grow in it over time. Okay? And then congenital abnormalities. Of course, there are some unique abnormalities or defects of this system, this architecture, that either makes it more prone to the VUR reflux or to bacteria entering the system, so on and so forth. So this reflux nephropathy, this is a certain subtype of pyelonephritis. Okay, it's typically associated with a urinary tract infection and a very aggressive VUR reflux. And in this reflex nephropathy, in its extreme case, you see some very aggressive scarring of the kidney itself, because this infection made it all the way up into the kidney proper and is causing major damage of that particular kidney. Questions over renal pathologies that we're covering today? Okay, let's take a short break and then we'll come back and dive into liver.